So here we go. This is the latest imaging. So we did the case review. After the case review, I'm like, hey, Vera, your diagnosis is pretty clear. You got microvascular disease. You had two MRIs that show that.
Yeah.
And then I go, hey, can you get another MRI? And then you got an MRI, you got an MRA, right?
Mhm.
And then you get the ultrasound of the carotid arteries, I believe, right? So,
Right.
and basically confirm the diagnosis here. Okay. So your MRA was good, meaning there's no like obstruction of the blood vessels or anything.
Mhm.
Well, okay, serious. White mild. Your brain MRI, mild to moderate amount of white matter disease is again identified in the supratentorial brain. Manifested as focal T2 hyperintensities that are scattered throughout the periventricular deep and subcortical white matter bilaterally. Yeah. So you know what that means? You know what hyperintensities are?
I do not.
So if you hyperintensity means that it's whiter on an MRI, which means it's an increased signal. So if you look at images on the MRI, you're going to see little spots and dots everywhere.
And what does it signify?
That means injury to the white matter.
I see.
Okay. So when you have neurons, like the very outer side of the cortex, like your brain, you'll see on the image, you'll see that it's gray. Let me show you. Brain. MRI. Like you see, some parts are white, some parts are gray.
Mm-hmm.
And the white area is like your myelin sheath, which is nerve sheaths that carry information across.
Mhm.
Your gray matter is like your neurons. So the pathways are white matter. Okay. I'll put small vessel disease. So what happens with again, we'll have to get the images, but from the report we can see how some of these are.
Yeah. Yeah, I did look up this photo.
See those dots, those little
Mhm.
white
Yeah.
spots there?
Yeah.
Those are hyperintensities. Those are white signals.
Okay.
That means those tissues are injured. Okay.
Okay.
Now, an MRI is only going to pick up a hyperintense signal when about 60% of that myelin sheath is injured. So you could have areas that don't have findings, but your physical exam will show impairment. Like, for example, areas that impact your speech, like your speech sometimes changes. Like you have a little bit of dysarthria now, your speech is not smooth.
No, it
Right.
is not. It is what I call stilted.
Right. So we call this dysarthria. But there's motor speech areas that you may have some lesions on, like these
Yeah.
white matter spots, or you may
Mhm.
not. If it's past 60% injury, then you can see that clearly on MRI. But your examination is your examination. Your findings, your physical function is your physical function. So if you notice a change in speech, even though you might not see a signal on there, it just means it hasn't gone to that threshold, right?
Okay.
So the good news with your MRI is
It did not progress.
it did not progress.
Yeah, I noticed that.
But anytime you're having symptoms, you're having them. It just may
Mhm.
not have reached those 70% thresholds. Does that
Okay.
make sense? So that's
Okay.
that's one of the things you have to also understand about your MRI and your case history and everything like that. So you've had 3 MRIs now that have all confirmed like these hyperintensity signals, right?
Mhm.
And they say it's white matter supratentorial. That just means throughout the brain. Okay.
Okay.
Throughout the periventricular area. Ventricles are these little areas, those black areas where there's cerebrospinal fluid.
Mhm.
That's an empty space. So all around it, they're saying it's basically going to look like something like this,
Mhm.
right? And then you have little spots all over the place, and that can cause a whole list of diverse neurological symptoms.
What I wanted to point out is that so it has not progressed, but when it was done the first time, my function was much better. I mean,
Yeah.
I still had those good periods,
Yeah.
and now it has not progressed, but I progressed.
Yeah.
What does that imply?
So this is the characteristic pattern of microvascular disease. Remember, I was telling you stepwise deterioration.
Mhm. But I kind of thought that there will be some findings on the MRI that would support that.
So yes and no.
Okay.
So with so here's the thing. If your case was only in something like multiple sclerosis, demyelination, so we'll
Mhm.
talk about that. You do have some
Mhm.
neurological autoantibodies, right?
Yeah.
But I don't think that's the main
Mm.
underlying condition. No,
No.
I think you may have a little overlap. That's not the main.
There's one that could imply MS or Alzheimer's.
Yeah, we got it. Yeah, the tau
Mhm.
antibodies. Yeah.
Yeah.
You also had some nerve sheath antibodies on that panel, but that's not the main characteristic pattern. So what's happening with the microvascular disease? Now, which is different than like MS, right? MS, like you get lesions on the MRI. Some get better, some get worse. If it's progressive MS, it keeps getting worse and worse and worse. Okay, so microvascular disease is different because they're very small little ruptures of the very end branches of the blood vessels.
This is what's happening in my fingers and toes.
No, I'm not sure what's happening in your fingers and toes. I'm just telling you what's happening in your brain. We have to see what's happening in your fingers and toes. They could have a lot of other mechanisms happening.
But the analogy is that very small the end, and it is very small the end.
We'll see.
Okay.
But in any case, as far as your MRI is concerned, is like microvascular disease is you can have a lot of deficit continue to show up and progress and have the stepwise deterioration, but you don't see big change in your MRI.
I see.
Okay, and also with these little small vessel ruptures, they could just decrease blood supply to a neuron, and the neuron isn't completely dead yet, but the function's gone for a period of time, and then it may heal, and you may have some deficits, but it never causes enough change in the anatomy of the myelin to show up as a signal.
Okay.
Does that make sense?
Are you saying that these signature attacks are the manifestation of microvascular disease, not mast cell activation syndrome? Because what I wanted to tell you that I started...
Well, let me stop you for starting, okay? Like you've been diagnosed, like I told you, the greatest hits: mast cell activation syndrome, Lyme disease, mold, all these things, right? So when your brain gets injured, whether the brain gets injured from a vascular insult, or the brain gets injured from trauma, like a brain injury, like a car accident, or it gets injured from demyelination, those surrounding immune cells are hyperactive.
You're talking glial.
Right, glial priming, right? Then anything you're susceptible to that creates immune response can cause neurological deficit with you. Okay, so for example, you clearly have multiple findings on your past file of antibodies, immune reactions to mold, right? History of mold being a problem. So let's say you do have mold reactivity, right? Like immune reactivity. You can get exposed to mold and you can lose function. So once your brain gets injured, you can get deficits from anything that creates an inflammatory response, because you get an exaggerated response in the brain, which makes the diagnosis tricky, and also makes people that are like one-sided, like, oh, this is just mold, like, oh no, this is not just mold. Like lots of people have reaction to mold, but they don't have this type of deficit, and they certainly don't have these.
Well, at this point, I have everything, and mold and Lyme and...
You do. Your immune system is in bad shape.
Yeah. And
you have lots of different triggers. So one part of it is one part of your case management is going to be, first part is diagnosis. Like your diagnosis is, I don't know how to tell you in a way, it's as clear as can be, okay?
To you.
It's right here in the MRI report.
Well, this is not the first one.
Yeah.
Nobody saw it.
Well, I think once you went to an emergency room, right? And you went, so listen, think about the scenario. You went to the emergency room with symptoms. They're looking for acute severe stroke. You show microvascular disease, and that can get written up as associated with aging. And because there are some people that have asymptomatic microvascular disease. So they're like, hey, you don't have a massive stroke. There's nothing wrong with you. This is an emergency. Get out of here.
It's like in Russia. You call the police because you were threatened. Somebody threatened you to kill, and they tell you, well, when they kill you, then we have the case, then we will come. But not before that.
But I would say 9 out of 10 people that were in the same situation as you would have the same thing happen. Because when you go into an emergency room with immediate onset of symptoms, they are looking for like a massive stroke. They're not looking for these, because there are a percentage of the population with microvascular disease that, especially in the early stages, don't have severe symptoms. Okay, and if you're going in with mild symptoms, just like dizziness, and you don't have like severe postural change, like spasticity, like someone's got a stroke, you kind of like, hey, there's nothing wrong with you. You're fine. Get out of here.
Yeah, but this is very new. I mean, this is like I started noticing maybe within half a year.
You mean your facial tone?
Yeah, not that just the tone. I do not know whether this is what you call the tone, but like this lack of movement, kind of some kind of deficit over here in the mouth area. So I do not understand whether. But obviously MRI is recent. It didn't show any stroke. So
again, it's not a stroke. It's microvascular little bursts.
So you say just the natural progression.
It's not natural progression, but you're going to have a stepwise deterioration. So you see this area of the brain? So there's different regions of the brain, right?
Mhm.
So if you get a little tiny stroke right here, it's going to impact your muscles around your lips. Then you get a little bit of little tiny microvascular rupture, let's say up here, can impact your hand and fingers. And then it can impact here. And then you can have a little bit of healing, so some of the symptoms improve, but then some are injured. And then boom, you get another one. And then that's the stepwise deterioration. They call it stepwise deterioration, meaning slow deficit. So meaning, like, 10 years from now, you're going to have more deterioration than you do now. Okay? Now the question is, can we clinically do interventions to slow that down as much as possible, to improve your function, and look at that from a dietary...
This is a big question.
Right, that's the goal. So the goal with us is to go, okay, you've got microvascular disease, let's make sure your stepwise deterioration is as minimal as can be. Let's try to improve your ongoing function as much as possible. Let's keep your brain as healthy as you can, right? You're definitely not like, you just have this weird pathogen, if we get rid of it, everything's going to go away. You just have a hormone deficiency, if you correct your hormone, it's going to go away. Like, you can't think that way anymore. You're not in the, no one's diagnostic mechanism, and if someone finds it, you're going to be cured. Like, your diagnosis is clear. You have a degenerative, progressive disease of the brain, microvascular disease, okay? Now the goal is, how do you optimize your function with it? Because you can do many things to optimize your function with it, okay? You can do many things to slow down the progression of it. But you can't have it be this mysterious disease you keep looking for and then wasting time and then not really jumping into all of the strategies you can do to vascular health.
Okay.
Make sense? Any questions with that?
Yeah. So the question now is, that main question, can we slow down the progression?
So it's hard to say.
Okay.
In one sense, because every case is different, and how do we know if we are? Because we're comparing you to you. Like, in a normal study, you have one group that's a control group, one group's the treatment group, and then after 5 years, they compare one to the other. They're both going to have some degree of loss, right? But they can go, hey, well, this treatment had an impact because compared to the other group, they're much, much better with this treatment.
Okay.
We have no one to compare you to. That's the problem with any progressive disease, whether it's Parkinson's or Alzheimer's or microvascular disease, or when it's progressive, you don't know if the treatment intervention is working because you have no one to compare it to, right? So there's a matter of like, for example, you have to move. Like, physical activity and exercise, which you've been doing, is one of the best things for your blood vessel health. It impacts all the pathways you want. Okay? So theoretically, if you continue doing that, that would probably be a factor of slowing down the progression of this versus if you didn't do it, right? Now, if you didn't do it or did do it and 5 years go by, you really don't know if one made a difference or another because you're only comparing it to yourself. So there's a leap of like faith of what things have been shown help vascular health that you employ, and then you won't know if it's helping you or not because you can't compare it to anything else. But I will tell you this: you will 100% go down to some degree.
That's reassuring.
Well, I had to tell you, and I'm telling you.
I'm joking.
Sorry, I'm telling you this because that might make you go, the diagnosis is wrong, the treatment's wrong. I'm not going to do all these vascular health strategies, and then it would be the worst thing you could possibly do. Does that make sense? And listen, just age alone is going to make everyone deteriorate to some degree.
I know, except my mom is 20 years older than me, and she's still selling her produce at the market, and I have a hard time going to Seattle on my own. I mean, I never do.
we got to work with what you got. Like, the thing is you get correct diagnosis, realistic intervention, monitor, look at function, see what's happening. Like, that's where you're at. Like,
okay,
I mean,
I got that. So my next question then is, so what injured the brain? This doesn't run in my family, but
yeah, you don't have the typical pattern. Like, typical patterns would be diabetes, hypertension, that really causes insult to injury there. There's a couple of things that are possible with your history. There's a possibility that it is autoimmune to the vascular system. You're having some vascular issues. There's some early research that that's a possibility. There are a group of people that have like very low blood pressure. I assume your blood pressure is low, right?
No.
What is it?
It's either okay or it is, at this point, it is high, can
Okay,
be
so-
high.
So we'll check that
But
too.
it depends very much.
Yeah.
Most of the time it is alright. But like when I got in the emergency, it was 180, right, Ellen?
That's actually, between the twitching and the high blood pressure is why, they send the urgent care center to the emergency room.
Okay, so you do have some vascular dynamic issues there. It could be playing a role. It's hard to say. I mean, the thing is, the typical pattern is overweight, diabetic, high blood pressure that starts getting vascular as they get older.
No, when I started with it, my blood pressure was normal.
But that's
for a long
just
time.
the most common. Doesn't mean other
Mhm.
patterns don't exist. You definitely have other patterns exist with normal weight, no high blood pressure.
Could that choking on the sand when I was an infant have any role? Because I was turning blue, so there was hypoxia.
I mean, you could have had hypoxia, like injury,
Mhm.
but it wouldn't progress into microvascular disease as I know it. I don't think you'll ever know, honestly, at this point.
Okay, I do want to discuss that linear.
Oh, by the way,
progression.
there's also
Mhm.
some early research that pathogen, like viral infection, can induce onset of microvascular disease, which you may have some links there. More than likely, I would say with your history, when you read through it, it's most likely immune activated inflammatory, something turned it on. And with any kind of chronic disease, it's like a mixture of many genes. It's not one gene. Many genes plus the right environmental trigger
Environment, yeah.
mixed together then
Yeah.
creates the perfect storm for some of these things to trigger.
Yeah, because I want to put emphasis on my reaction to stress, emotional stress.
Yeah.
So when we were moving from California to Washington in 2003, it was like this, what I call signature attacks. It was like never abiding for, I don't know, maybe 2 months or something. And I know that it was related to the stress.
Sure.
And then it kind of subsided, and then there is this very clear tendency, and like I guess I pointed out in my case, that my son, when he was, I don't know, middle school, he would say, "Oh, I know how to put you in bed," because he knew he got me mad. That is for me.
It's terrible.
I am, and with him having attention
He didn't
deficit,
know
right?
anything.
It's like I was mad all the time. So would that be so? But again, then it started. I was very stressed at that point too, because being a recent immigrant and then having to deal with my good husband and his views was very stressful.
Yeah.
But so how does stress fit in this picture?
Oh, stress always flares up every vascular pattern.
Okay.
Because your stress hormones go up, your anti-inflammatories go down, you get vasoconstriction, you get into sympathetic mode.
With this
Yeah.
stress.
When
Okay.
any history of vascular disease, like mini strokes or actual significant hemorrhagic strokes or even embolic strokes that break off, stress is always the trigger.
Okay.
Like stress destroys vascular health. Movement, exercise, relaxation optimize vascular health. It's very simple.
Yes.
So the thing is when I was there's a point. There's a point to just shift into how do you function with what you have. How do you function? And I slow it down. Like that's where I think I can try to help you with the role. Like you're not going to this isn't a mysterious diagnosis. And the signature attacks. How'd you come up with that name? Signature. What do you call it? Signature attacks.
Signature. Wait, how did I come up with that? Because I was searching the literature everywhere to see who else is having this trio: sudden fatigue, enormous weakness, and burping.
Okay.
So I never found it. So signature means nobody else has it, just me.
Okay, so I'm like, I heard you. I googled it. I'm like, what is signature? I never heard of this. I'm like, okay. Then I talked to you. Well, okay.
Yeah.
So basically, the burping is basically lack of blood flow to your vagal motor nuclei. It's a lateral brainstem. It means that your basilar branch of your pontine artery.
Oh, who would know
That's
that?
what that is. But everyone would know that. That studies the vascular system.
Okay.
So in any case, that's what we're seeing here. Now the good news, so your MRI shows it's not progressed, but you're looking at white matter, and you could have degrees of injury under that are not significant enough to show the intensity. Okay, and then I'll do a very thorough exam on you today, like front to the back of your brain, top down. We'll look for everything, and then you may have findings that correlate with the MRI findings and some that don't because of what an MRI can pick up, right?
Yeah.
But once we get the images, at least they can kind of get a better idea. Like you have one major lesion, largest lesion was demonstrated, mild left frontal lobe. So that would have expression maybe on your right side if it's on the motor strip.
On the right, no, it is my left side over here that I have lots of symptoms.
No, but as far as your extremities go, because the pathways cross.
I see.
Okay, so I don't know if you have weakness or things on the right side, do you?
No, it is my left side that I could notice some weakness. Not so much now, but earlier that was kind of pronounced.
I'll go over those with you as well. Okay, that's what the recent MRI is. Do you have this in an electronic format?
I would think so because this is how we got it.
Yeah,
And-
it's PDFs.
Because the one you sent me is missing words. You can see like there's an eye missing there.
Mhm.
Huh.
Or I can leave it for you, or you need it online.
I need a tech guy to figure this out.
Well, they gave me some things, if I don't have it, I'll scan it from the
Yeah.
original.
Okay.
Yeah. Okay.
Okay,
Then
good.
we can scan it and send it to you.
Okay, great. All right, so that's the main thing. So the MRI was fine. Carotid artery scan was MRA was looking at like blood vessel obstruction. It doesn't find microvascular disease because there's no occlusion, and then your carotid artery ultrasound was good, which is good. Right. Okay, so that's that. Now you made this new sheet. What do you accomplish today? See if the physical exam and recent imaging results give us a clear diagnosis. Your diagnosis is clear. Like, I don't know, you got imaging that shows your brain has hyperintensities all over it and has signs of vascular disease. Okay. Signature. Okay. Understanding the root cause of my health and constant signature attacks. So let me explain these to you. Your symptoms are going to be directly related to what area of your brain gets the attack. Right? So if your hands and feet also have symptoms, then the area where it represents your hand and feet, like I showed you that image of, is probably having a little rupture there. If you're getting hiccups, it's your lateral brainstem area, it's the vagal area, it's the lateral branch of the pontine artery that's having a little rupture there, or even ischemic change there. Okay.
Okay. Can I
Change in
ask-
voice strength. I'm sorry. Change in voice strength. Change in breathing. These are going to be also brainstem autonomic centers. Okay. Yeah.
Here comes my brain. I forgot what I wanted to ask you.
No problem. We can go through the list you made.
Okay.
And you said yes. You made this list because you have really bad days, right?
Yeah.
And you were worried that you would come in and not be able to function.
Yeah, I'm a pretty good day today.
Okay.
But
Yesterday would have been a wreck.
And what were your symptoms yesterday?
it's like I can describe it that as if you put a sack over my head, and then with that sack on, you submerge me under the water. And it's whatever is going around me. It's like I cannot understand what people are saying. Not I don't understand some.
Yeah.
And here is this enmeshed in this disability to discern voices, what they are saying, when there is so much background noise.
Mm-hmm.
And I read about this. This is some part of brain that is affected.
Auditory association cortex. Yeah.
Right. So, and it's like my head is about to burst. It's like it is stuffed with cotton, and this increased fatigue, increased pain, and this pain is jumping. I mean, it's jumping all over the place all the time. Anyway, but it is increased. Like it's if it is usually 2, 3, now it is 4, 5, 6. And it is all at the same time, and I have to function, I have to go. Luckily, I have my husband. I wouldn't be able to make this trip without him. It's like I'm disabled because it's like I'm like that rabbit in the
Yeah.
This.
Okay. So And that can be different on a different day, or is that always the same?
The intensity of it, yes, but it usually comes nowadays like previous night. This night I slept, okay, and that is like one of the best nights I slept, because I got to sleep about, what, darling, 10:40, something like that, and I was up sometime before 6, so this is just wonderful. But the previous night I go to sleep, and this doesn't happen usually, this pattern, but I go to sleep as I usually do about 10:50, but 12:30 I was up, and my head, I was feeling okay, my regular, the previous day. So now I'm up at 12:30, and my head is still relatively clear, I'm still relatively okay, but then as the night progresses, I cannot get to sleep, so by the morning my head is again filled with cotton. There's so much more headache. I mean, the headache is there all the time, but it is so much increased. And then it's like I didn't have the signature attack because I was not burping. Now I do not have this fluctuation because I'm always fatigued and weak. But there's no burping, so I know I do not have the signature attack. But there is this, it's like all my symptoms are mainly in the head.
Okay.
This is, and then it's like I do my coffee enemas and a lot of other things that I do with coffee enema, and then gradually after that I get better.
Okay. So you have to understand a couple things. When you're having a new onset of a new symptom, like all of a sudden if something new happens, like for example your speech completely changes, it hasn't been that way before, that is more than likely a little vascular burst, okay? However, your brain at this point has its glial cells completely activated because you have injury throughout your whole brain. Like there's hyperintensities all throughout your brain.
Mm-hmm.
So those immune cells all throughout it are overactive, and their job is to basically clean up debris. But now there's so much debris from all this injury, they're just on all the time. Okay? All it would take is you to activate your immune system that then sends messengers to the brain. Like when you trigger, let's say you eat something you're reactive to, or you have a reaction to, you go into a damp building and you have mold reactions, or you get exposed to mycotoxins, things that you have some clear sensitivity to in your past lab work. That is going to heighten your immune response. Your immune response is going to release these inflammatory proteins called cytokines. They cross the blood-brain barrier, and they just have their effect, and then they'll just cause nerve activity to slow down. So nerve connection speeds all slow down. And some people call it brain fog. With you, it's very severe. So like you're like underneath water, and you can't have clear function. It's just a clear synaptic activity. So you're having like a very extreme pattern of brain inflammation, brain fog. So that's important for you to understand too, because what we're most worried about is new onset of symptoms. New onset of symptoms means you had another potential injury from a vascular burst, okay? But if it's the same, no new symptoms, but you just have the symptom you're explaining about, where you just feel like you just can't have your brain work and things are working, that's most likely just activation of your glial cells, severe neuroinflammation, okay?
Yeah. There was some time when I thought that I have this leaky brain, so I did the testing. It doesn't show you, but you say the cytokines come.
They cross.
Cross.
You don't have to have a...
Yeah.
And you will probably have your blood-brain barrier permeability change here and there with that question.
I think it was because with that, unless heavy metals can cross the blood-brain barrier, they can.
Heavy metals, yeah.
They
no,
can.
Only if it's breached.
Because I described that severe reaction for the MPS. Yeah.
So let me go over those things. Let's talk about a few things. First of all, let's stay consistent with your symptoms right now. So most of the time, you're just getting these. Can we just call them like brain foggy symptoms, right?
Okay. Yeah.
Just to communicate. So you get these brain foggy symptoms, which means you just don't feel like you're underwater, right?
Yeah.
how often do you have that per week?
2 or 3 times, right, darling?
That's probably about right.
Okay. And then with those, the main question is going to be, what have you found triggers them? Okay, but we'll get back to that. The second part is that I want to ask before we move on to that is, how often do you get new onset of deficit? Like a new deficit that showed up, like a change in your voice that's different, or a foot drop, or anything like that.
Okay. So, thinking about the triggers.
No. Second question first.
You want to start with the second. Okay. I do not think that I have new onset symptoms often.
Well, that facial thing.
Yeah, like that
This-
facial thing would be a new onset.
Yeah, this would be new, right?
When was that?
I cannot tell you because
Month
see,
or
you
two
have.
ago? I couldn't confirm it, but you were thinking about a month ago.
Yeah, I think maybe like 3 months within this time frame. I do not know because you have to look in the mirror to know. You need to be talking as you're looking in the mirror to notice it.
Yeah.
And so when I noticed, this is when I was looking in the mirror talking, that's when I noticed, but I do not know when it came. But other than that, darling, I do not know. Maybe there is new symptom, and I do not know whether this would be related to what we are talking about. I mean, I have these symptoms come and go, and because I was in the emergency when the nurse told me to go to the emergency when I had kind of like heart attack,
Yeah.
and that was modeling 10 years ago. I was waiting, and then I called the nurse, and she said, "Call the ambulance now and call me that after it comes."
Yeah.
And I went, and nothing. I was fine. My head was fine, no problems. It's like I feel like a fraud. So the symptoms I'm talking about now is kind of like pain that kind of feels like urinary tract infection, but it is not because I had a couple of those. So it is something going on there. It's kind of like this tinge of pain. And would you consider this in this area?
No.
No. Okay. So other than that, I cannot tell you.
Okay, so let me explain. Because one of the things that, like, we all have to communicate with and be aware of is
Okay.
new onset of neurological.
See, and I do not
symptoms.
know whether you would consider it.
Neurological
that's why
be change in motors, change in your strength, arms, leg, face. Okay, change in your strength of your limbs, change in the strength of your voice,
Okay.
double vision.
I do not have.
I'm
that.
just saying.
Mhm.
New type of dizziness.
Okay, I
Okay.
don't really think I have much dizziness.
No, I'm just saying in the future too.
Yeah,
Any kind of immediate sensory changes where your hand feels numb all of a sudden, or you get tingling sensations.
I do have that.
So those are going to be neurological symptoms. Okay.
But they are not new. They are just coming and going.
Okay, well those are those are the things that we have to communicate. So
Maybe this is new because I know that sometimes when I was still a child, I would have this finger go white and numb. But now I woke up several times that like this one got numb and this one kind of got numb.
only there in those areas.
Only in those
Yeah,
areas.
see, those are ulnar nerve. Those are ulnar nerve.
So this is what you mean, right?
Maybe.
Mhm.
So what we need to do is communicate what you're experiencing. If you have anything new. So you're gonna start sending me, like, the way we'll work through it in this case is you're gonna send me an update once a month, every week.
Okay.
I'm not gonna respond to you. It's just gonna be a
Yeah.
journal that you're keeping,
Mhm.
and then when we do a follow up in a month or in 2 months, we're gonna pull up all of your emails so we can look for patterns and look for what symptoms are. Because
Okay.
with a case like yours, like, I can't get on the phone with you in 2 months and go, "How did you do the past 2 months?" Because it's the most inefficient way to figure out like what actually happened in 2 months, and then you're trying to recall, and I'm trying to,
Yeah.
and it's like it's terrible. So
Yeah.
what we need is we need a weekly journal of some things. One of the things we need a weekly journal of will be like any new onset symptoms. Okay,
And let me make sure that I understand you.
I'll email you exactly what I want from each
Mhm.
week, so it's clear.
So no. This is. Does it mean when you say new onset, it's something new, or it just comes at those symptoms that come and go?
Well, first, for sure, I definitely want to know anything completely new. Okay,
Completely.
and then we're gonna categorize your other one as your like brain fog symptoms.
Trace this
Yeah,
existing.
brain
okay.
fog ones, existing symptoms. Okay,
Mhm.
and then how many of those are good days versus bad days? So you're saying now it's about 2 to 3 days a week.
Yeah.
Okay, where you just completely lose function that day?
No, I wouldn't say that I completely lose. I still get up and I still do as much as I can.
Okay.
I mean, it's not like I do not have strength at all. And I know that I need to be moving, and this is the kind of person I am. I get up, whatever the symptoms are, unless it is like I completely am wiped out, that then I would lie down. But otherwise, I get up and I go and I do as much as I can. I did change a little bit because I used to go whole day. Now it is sometimes 2, 3 o'clock. This is when my day is done. I go to bed if I can take a nap at that time, if I can rest, do my meditations, do my other things, read, learn, and then he cooks dinner, and then it's...
Okay, we'll go through your average day too. But let me go back to your brain fog symptoms that are 2 to 3 days, okay? How many times a week are they totally incapacitating where you can't function?
I wouldn't say it happens every week.
Okay, how many times a month?
It varies.
Not often.
Not that much nowadays, because nothing much going on in my life. But maybe 1 in 2, 3 months, darling, would that be?
Perhaps.
Because you said yesterday you're fully not functional.
I still came here, right? I still went doing what I did, and this is what I mean.
I see. Okay. So you can still push through if you hit.
Yes, I can push. I do push, and that's because this is my state of being, right? If what I'm experiencing on a daily basis happened to me when I was all right, I'd be in bed, okay? But since it is an everyday occasion, and I have to live my life, right? Whatever, much of that life is left for me, right? Just the house, nothing else. So I still get up and I cook and I clean and I garden and go for...
That's what you have to do.
Yeah.
That's what's going to keep your brain healthy. If you stop doing that, you would deteriorate very quickly. So the minute you stop functioning and pushing yourself through, you would deteriorate. Now, we got to talk about pushing through and energy and everything so forth here. Okay, so 2 to 3 times a week you have this severe brain fog, but you're able to do things. And maybe once in 3 months it could be so bad where you just can't function, right? Okay. And then you're not really getting a lot of new onset symptoms, except the last thing was this facial lip motor change there, right? Which all really indicate that you're probably just dealing with lots of brain inflammation from past microvascular injury, and that's really the main cause of most of your symptoms. And you're not really progressing rapidly. If you were getting new symptoms all the time, then we're like, okay, you're going down quick. So that's really good sign. Okay, that's really good news. And also your MRI, even though it's not completely most sensitive for back vascular, it's it is not.
Is there a test like would Dr. Amon's imaging show us more?
No, it'll just be a PET scan. It'll just show activity of different areas of the brain, and you'll end up with like 30 antidepressants recommendations and 30 supplement recommendations and a fancy report. It's
I did like that report.
Yeah, that's what I'm saying. If people love the reports, it's not precision clinical. It's very general. Okay.
Do we want to talk about the triggers?
Yeah, we can do that.
Because this is very important, because I've been trying.
So you're talking about your brain foggy
hard.
symptoms, right? Your brain fog symptoms.
Right. Like whatever triggers me, right?
Okay.
Why couldn't I sleep the previous night? What happened?
Okay.
What? Nothing happened.
Okay.
It's like...
Let me explain
Okay.
triggers to you. There's 2 kinds of this, so this might help you as you look for them.
Okay.
For sure, one type of trigger for you is going to be anything immune reactive. Immune reactive would be like chemicals, foods, infections, stuff like that, okay? The second one is just going to be your neurons not going past your endurance and crashing.
Yeah, but something has to push them.
Right.
Yes.
But it could be activity. It doesn't have to be food. It could be you did too much. Like traveling could be too much. If you have motion, movement, crowded places, for some people it could be too much.
See what happens. Okay, I was not well. I started getting better, like the third part of the flight. So if we follow that pattern, that I should be getting worse, And it went the other way around.
Right. So that's probably not the fatigue issue. Okay. So let's talk about the difference, because you're the fatigue issue is like we have to know what part of this is fatigue, what part of this is immune activation. Okay. Because the intervention would be more mitochondrial energy functional treatments or more immune activation. We're gonna have to do both to some degree, but what's more important?
Mm-hmm.
But when you say like you've done it 2 or 3 o'clock, that would be more of an endurance issue.
Yeah, I do have problem with endurance.
Okay, so let's talk about endurance first, and then immune triggers second. Okay, because
Okay.
it's easier to find the fatigue.
Yeah.
So in your average day, Vera, what time do you wake up?
Oh, that is a good question, because here we have to talk about insomnia.
Right.
I can tell you for sure, I get out of bed at 9 o'clock. When I wake up depends very much upon my night. So it can be 12:30, like it was. It can be 3 o'clock. It can be 4 o'clock. It can be 5 o'clock. It can be 6. And it has never gone. It was close once to 7 o'clock that I would wake up, but that is like once in half a year.
Okay. So I know you're having a problem falling asleep and staying asleep with your
Everything.
Okay, everything. And now getting up and not being able to go back to sleep. On an average given night, how many hours of sleep are you getting?
About 5.
Five good hours.
Yeah.
Okay. Can you get more, or is that pretty much it?
Well, like if I sleep almost till 7 once in half a year, yes, but
Okay, fine.
that happens very
Very good.
seldom.
All right. So, but you're out of bed by 9 o'clock.
Yes.
Okay. And then
So I wake up, and depending upon what my head feels like, I can either study, still have your books at my bedside.
Nice.
I study and prepare for the day, like to-do list, like my diary, and study and read politics now, what's happening in
Yeah.
Ukraine. 9, I'm up.
Okay. And then what's the first time you eat, and what are you eating?
I eat right away. If my husband has prepared breakfast, so I eat within 10-15 minutes. If I have to prepare, so it will be like half an hour
I know
later.
you made a list of foods you have and all that. We'll go over that.
Right.
Okay. 10 to 15 minutes you eat. So you eat right away.
Yeah, I eat. I cannot tell you that I have appetite or I feel hungry. No,
No.
I have not been hungry or have appetite for decades. But I eat according to the clock, and unlike when I was like a teenager, now I do not have to force it. I do not have to eat like my mom described. You eat like as if your own body. No, I eat food. I'm okay. I have no appetite. I have no hunger.
Okay. So then 10:15, you're done eating, right? Then what?
I do the chores around the house, gardening. If I'm up to it, I go for my walk, and that goes all the way till 2-3 o'clock in the afternoon.
Okay. And then what?
After 2-3, then I go to bed, and again, depending upon how my head is feeling, I either study, read, or do my meditation, do my some other things that I do at this time. I mean, healthy things like all these vagus nerve things, and for next time I'll prepare what I do with all these enhancing health activities. And this, I can get a nap, not every day, but if I feel like I'm doing this, whatever I'm doing, studying, reading, I feel like sleep, I do get a sleep. And this happens all the way till dinner time. Usually it's my husband nowadays that cooks dinner, so I have dinner. And then lately I've been doing puzzles, and then it's television. I did try to do these brain exercises, darling, what it's called.
Oh, I've forgotten what it was called.
Yeah, but those to enhance your brain, but because I cannot work on the computer gives me a brain fog and discomfort. I describe those symptoms, so I am electromagnetically sensitive, so I cannot really work on that. And then I find it frustrating because I cannot do it well. So I stopped doing that. But yeah, then I watch a movie, watch a lot of Ukraine events nowadays, and then it's bedtime.
Okay. One sec. Okay, so coffee enemas help you.
Yeah, this is the only thing that helps me, but it also comes with other things like vagus nerve things that I do with that, and some, how do you call it? Forgot the word. When you touch, like I do these things, how do you call it?
Yeah.
So this one.
To stimulate your vagus, your upper ears.
My ears. I don't think this is related to vagus nerve, is it?
The sensory portion of the vagus has a part of
Over
it.
here,
Yeah.
I do this like I do this way and I do this way, but yeah, this kind of exercises. I also do the gagging
Yeah.
with that.
Okay.
Yeah, this kind of activities.
So you're gagging, you're doing coffee enema, you're rubbing your ears. What else?
Yeah. Well, there's a whole procedure. Do you want me to tell you?
Yeah,
Try
tell
to
me.
remember that, because I can think of it and write for the next appointment.
Just give me a general
very
idea.
thoroughly.
Yeah.
Yeah. So.
And how long is this taking you doing all this?
An hour and a half, 2 hours.
Hour and a half to 2 hours.
Well, you need to understand that I cannot just do coffee enema like 15 minutes and that's all. I cannot hold it. I read
read
it that with time you will be able to. I'm not. And it also depends upon whatever is going there too. So sometimes I can hold it for like a minute, but sometimes it's like 30 seconds and I have to start it all over again, and this can be 4 or 5 times that I have to repeat it.
Okay.
Because whatever is going on, my body is not adjusting to it like it should.
Okay, your morning walk is worth, she'll typically go a mile uphill before turning around, sometimes maybe a mile and a quarter or so.
Is that a good idea for you to walk far away?
Yeah.
Are you sure?
It's not far away, because it's like I'm listening to my body. Okay?
Okay.
So when it tells me that I should turn around, I do turn around, and I want to tell you this. I do not have chronic fatigue in that sense that you're talking about it, because activity does not aggravate me.
Yeah, I don't think you have chronic fatigue syndrome.
Yeah, it does not aggravate me. If anything, it makes me feel better.
Yeah.
So I do walk, I listen to my body, and I have to go up the hill at first, and this is where I feel the symptoms coming on first. So then I do my exercises, stretching exercises, and then I turn around.
You said you also do balance exercises.
Yeah, well, this is part of that
Balance
series.
exercises.
It's about 10 minutes of that, and balancing is included.
Okay. Yeah, so you put down things that really help you is coffee enema, the walks, right?
Mhm.
FODMAP diet. And
It helped me. I'm not there anymore. It created side effects for me as well for the diet, but I'm done with that. I am in a little bit different situation with the diet now. Mhm.
What do you mean?
Well, I kind of moved away from that when I thought that I must have be done with SIBO. And
Do you get bloating and distension when you eat certain foods?
I don't think I ever had distension, and my SIBO was very minimal. It was supposed to be less than 10, and I was at 10, so it was very...
No, it was positive.
Well,
Because in the last 90 minutes you went up over 20. That's considered
Okay.
positive. Your actual levels of methane were low, but your hydrogen levels went up to like 50, 60 the last 90 minutes.
was it hydrogen or was it methane?
Maybe, let's double check.
I think
But
it was
It was
methane.
methane? Let's check. I have it, but it was
Yeah.
positive.
It was positive. That's why I went on that diet, and then I thought, well, it's like I should have done, logically thinking, I should, after I was done with that, I should have done the test again to see what I was done. But since you have to ask the doctors every time, can you do that for me? And I was fired because I kept asking.
SIBO has a 98% recurrence rate with treatment. and it's ongoing.
I do have. I have never had I have never had bloating. Right, my stomach wouldn't get bigger on my waist. I do have flatulence, sometimes more than at other times. I maybe have less now that I stopped taking probiotics.
Mm-hmm.
But yeah, I have it. I have bloating, except that is that SIBO that is causing it.
But you notice diet, since you've not been on a FODMAP diet, change your brain fog symptoms?
No, I can't tell you that.
Have you ever tried a ketogenic diet?
I didn't purely. I do have take much more fat now that I decided that Americans were not right and fat is not bad for you after all. In Ukraine we eat a lot of fat, and salo is the Ukrainian word for pig fat that you eat with garlic and bread. Plain like this.
But that's eating more fat, but that's not ketogenic. So ketogenic is you're actually in ketosis. Have you ever done that?
No, I did not do. I did try to. We did buy those strips and tried. 0.3 was the most that I could get.
But you were into ketosis then? You didn't have 0.3, okay.
Yeah.
How long did that last? How long did you do that for?
Well, you better ask, when did you stop testing?
You still in ketosis?
I do not know because I stopped testing. So.
Okay.
So
when you were at 0.3, what was your diet like?
Good question. Well, we are taking MCT oil all the time now.
Okay.
I do put more fat. I cannot tell you that I did more than that when I did have 0.3. I mean,
So Vera, there's a couple things you're saying that scare me a little bit.
Oops.
Like if you have high fat, but you're still having carbs and insulin, you're actually creating a very vascular inflammatory response.
I do not understand that. Can you tell me more?
So if you take an
Low
MCT,
carbs.
if you take MCT and you're still not in ketosis, it's very inflammatory.
I do not know whether I am in ketosis.
Right, exactly.
Okay.
So that's the thing. Like so,
you're saying that I need
if
to
you
be tested.
if you have more than 20 grams of carbs a day, let's say for example, okay, then you're probably not in ketosis.
But I was still at 0.3, so you say I am in ketosis.
I don't know. Most people wouldn't be. Okay.
Okay.
So the point is, if you're not in actual ketosis, and then you're taking saturated fat like MCT, that's like the worst thing you could do for your blood vessels. You shouldn't be using MCT unless you're completely in ketosis all the time.
Oh, yeah, that really?
Yeah.
So the most like anti-inflammatory diet for the brain to get rid of inflammation and to make the energy pathways more efficient is to be running on ketones. Okay. So you can also get into ketosis if you go long periods of time without eating, like because you don't eat that. It just seems like you don't eat you don't eat very often, and you don't have an appetite, so you may not know it's time to eat or something. But if you're fasting for a period of time and you measure ketones in your ketosis, that's fine. But then let's say you had something to eat that secreted your insulin also. Maybe it was low carb, but it was still a carb, and you exceeded your carbohydrate levels to be in ketosis. Now, when you eat high fat, it's not a good idea. It's going to cause inflammation.
Okay.
So, are you open to going into ketosis and doing a strict ketosis diet for a while and see how you feel?
Yeah, we can go ahead and do that. The reason I do not go for fasting, my husband doesn't eat on Tuesday.
I'm not talking about fasting. I'm just talking about fasting could just be time restricted feeding, meaning from your first meal to your next meal. I'm not saying like daily fasting.
I do not have a snacking habit unless I'm forced to because of this emotional eating that began after the war.
Anytime we see someone who's got significant neuroinflammation symptoms, we immediately attempt ketosis because it's shown in multiple studies now to have a very profound effect, which you can't get with any other diet. So
I'm willing to go ahead and try and see what that gives me, but it's like I'm also, because I do not understand and we're
I'll
going
walk
to
you-
talk
I'll walk you
about
through it.
triggers here because I do not understand what triggers me. I'm trying to kind of like, I have to carry myself like precious vase, right?
Yeah.
Cannot stumble because it falls apart.
Yeah,
So
that's
it's like, if I were able to understand what triggers me, then I'll be more aggressive with approaches, but because I do not understand and do not understand the way to figure that out.
Okay, we'll get to that. We're still on one of the triggers being like energy function and how your energy is throughout the day. So we're kind of going through and trying to figure out like what happens through your day, and then we got to like 2 or 3 o'clock, and then it seems like you're doing a lot of activities, which means your brain function and endurance is still pretty good.
It depends how I'm feeling on that day, but the main symptom that puts me in bed is back, like between back pain between my blades.
Yeah.
So here I am going around these things, and I start feeling that pain, and it is getting more and more bothersome. So at some point I say, okay, it's time to go lay down.
What time do you go to lay down?
Yeah, it's 3 o'clock.
But you said 2 or 3 o'clock is when you're doing your crossword puzzles or
No,
afterwards.
meditation. Oh, that's afterwards. So up until 2 or 3 o'clock.
Yeah, I'll get her up. I'll get her out of the room at 6 o'clock and feed her dinner, and she'll do crossword puzzles and listen to news after dinner.
What about the walk? What time is your walk? I'm kind of confused.
If I didn't do it in the morning or after lunch,
I see.
then it's not done. And
But you know, you also do the in-house dancing to the music if you
Yeah.
can't get out for the.
yeah, I like to dance, and so this is my exercise type of exercise as well.
Okay.
I do dancing, then I go do this Gupta limbic system retraining.
Okay. Do you get really tired after you do those or not? Or do you feel better?
After dancing, after the work, no, I do not feel worse.
No, after the limbic retraining thing you're doing.
No.
Okay. Okay. So then you go to bed.
I'll massage her shoulders before she tries to go to sleep.
Okay. And what time do you actually start to sleep?
So it depends. So 10:30 he comes to get me. It's bedtime. 10:30. Then I listen to my body when it tells me I will be able to get asleep. Usually it's around 11 o'clock. Usually. Can be like 10:40, 10:50. And then if I still do not feel, if my body doesn't tell me it wants to sleep, I take off lights at 11. And then good luck. Most of the night I do get to sleep at that time. But occasionally I cannot get to sleep, and I wait maybe half an hour or something to see whether I would still get to sleep. But if I didn't get to sleep like within 5 minutes, I usually do not get to sleep. Then I get up, and depending upon how my brain functions, it's also is either I read, study, or I go do the puzzle, or I go watch a movie. And then again, I'm listening to my body when it tells me that it's ready to sleep. And the moment it tells me you're ready to sleep, I go to bed, and then I get to sleep.
Well, so what time is that typically? Between
Oh,
2 to 4? 2 to 5?
No, there's no any pattern there.
No pattern there. Okay. But you're getting 5 hours of sleep a day.
Right, like if you average.
Okay. Is it continuous sleep?
Yeah,
Okay.
most of the time it is. I could wake up maybe for a second. And usually what wakes me up is the heart wave. Okay, I wrote down here, it's very bothersome because it's like, it's not enough that I'm either too cold or too hot most of the time. And I'm pretty comfortable here. And as we were going here, I said, I forgot to bring my sweater in case I'm cold in the office. But I'm okay. At this point, my feet are getting cold, but other than that, I'm comfortable at this point. But throughout the day, it's either I'm too hot or I am too cold. And tell me what I was going to say.
Well,
So about hot waves. So this is what wakes me up by the morning, like 4 or 5 o'clock. It is a hot wave because 10 years postmenopausal, I have these heat waves, and
you've had it for 10 years since menopause.
yeah,
Since exactly timeline with menopause for 10 years.
it did start with menopause. I did have hot waves at some point in my late 30s or early 40s with no menopause.
Yeah, I don't think this is menopausal.
But this is, can you tell me what it is?
See, with menopause,
It did start this time very consistent with menopause.
Okay, so you could have vascular dynamics and thermoregulation issues unrelated to your hormones. It could
Mhm.
just be from the brain. Your thermoregulation
Yeah.
centers are off.
Yeah,
Hormones directly impact the thermoregulation centers of your brain.
right.
That's why they have the effect.
Okay.
You could have your thermoregulation of your brain not functioning.
It is not
Okay.
functioning.
So with menopause happens with most women unrelated to the inflammatory condition that you're dealing with. They lose their feedback loop between the ovaries and the pituitary as a
Okay.
normal part of aging.
Mhm.
Their follicles no longer respond to follicle stimulating hormone, and their estrogen levels start to fluctuate off and on until they just get stable. And during those fluctuations is when they have hot flashes.
Okay.
And if they just suffer through that and not do anything, they would have their levels drop. They would no longer have hot flashes. Hot
Oh,
flashes are
nice.
not. Hot flashes are caused by spikes.
Mhm.
They're not caused by like ongoing for 10 years.
Yeah.
And if you had it in your 30s and before, it's probably not that. Now, when you become menopausal and hormones do fluctuate, you're going to be more prone to thermoregulation issues because hormones are also a contributor to modulating that. So,
My thermoregulation is getting progressively worse.
right, and this goes back to stepwise deterioration. It's
Okay.
characteristic of microvascular disease. So, now when you look at your panels, like your hormone levels are low whenever you check. Have you ever thought taking replacement hormones or not?
No, because and I write here, my grandmother and my aunt died from gynecological cancer.
What do they have? Ovarian cancer? Or?
And I cannot tell you because, see, nobody was telling you much at that time in Ukraine, and then again, nobody even would pronounce the word cancer. It was very scary because it meant death. So, and I was, nobody knew, I didn't know either. I know it was pelvic area. It was not breast, but this is what it is. And then I'm thinking, obviously there is something genetic here, and I'd rather have COVID to die from, not cancer.
I understand. So if you just look at the mechanism of neuroinflammation, microvascular disease in your age group, they would be very protective for your brain.
That's what I know, but I was kind of like thinking maybe I should get into that if you think this is the right
Well,
approach.
yeah, I don't know if it's the right approach. I can only give you the evidence and you decide what's best for you, especially if you have risk in your family, right? Now, well, how old were your family members that got gynecological cancer?
Yeah, pretty young.
Pretty young?
But my grandma was 54, I think, and my aunt was 60.
So there's not many things that can have a huge impact on this, your microvascular disease. There just
Mhm.
isn't many things.
Mhm.
And to what degree?
Okay.
Hormones for sure have the potential to have a very powerful impact, especially if you
Mhm.
are deficient, which all your lab testing
Yeah.
indicates you are.
Yeah.
But with hormones, when they look at the research generalizable to the whole population, they find, there's not much risk. But that's not about that. It's about individual risk, individual genes, individual family history.
Mm.
Some people have estrogen receptor site sensitive, or estrogen positive cancers, as a mechanism. And not all those screening tests have been completely identified. They found some for like breast, but it's not something that's clear. But if your brain is going to deteriorate.
It is.
It's going to continue to deteriorate. Hormones are one of the few things that can absolutely slow that down based on what's been published. You may have your own unique response to it that could be different than anyone else. Like you might get the wrong dose and get more anxiety. You might have to play with it and figure that out. But it's one of the very few things you have that researchers clearly show that can make an
Make a
impact.
difference. Okay.
So you have to think about that maybe a little bit more, because there's not many options here when we look at.
I think I gave you the thought. So yeah, I would appreciate your guidance in that.
My guidance is you have to make your own decision.
Well, I have already. I have.
Okay.
Let's go ahead with hormones, and let's.
So then I
figure
would
out
say make sure you get an ultrasound every year as a screening test,
ultrasound.
and get
Mhm.
like just
Would-
get a
would-
gynecological screen that includes an ultrasound every year.
Mhm. Would MRI do a good enough job?
It's going to be much better with an MRI. It's not something that's routinely done unless they
Mhm.
screen with an ultrasound first. If you have
see.
access and availability to it, then you should definitely do that. It's just
Mhm.
ultrasound's inexpensive, quick. They can see if there's any kind of growth or masses.
Okay.
So frequent gynecological evaluations because of family history risk,
Okay.
and then maybe HRT would be one option, or HRT would be hormone replacement therapy,
Okay.
right? Or continue what you're doing now because you're really concerned about the risk.
No, I would prefer that we find the best way to monitor whether there is any complications of hormone replacement therapy. But yeah, I do want
Okay.
to see the to try the replacement.
Okay, so let me talk to you about that a little bit.
Okay.
Hormone replacement therapy is like the Wild West. People
Yeah.
doing all types of things.
I
Okay.
read a little bit about that.
So conventional, like insurance model would be, you're just going to take synthetic estrogen, synthetic progesterone. We don't really care about the dose. We don't care about checking your levels. You're just going to get both,
Mhm.
and that's the that's the basic model.
Yeah, it's a 15-minute.
That model,
Yeah.
a lot of people don't like because they're like, how do you know what my levels are? And I don't. Maybe I'd rather have a bioidentical than just some synthetic form. And then those are different opinions come in. And then the lab range of hormones, like no one has agreed on what's normal. They're all over the place. They're all over the place from lab to lab. They're all over the place from medical organizations. There's no like perfect level. And then even within the lab ranges, you have some practitioners that go, well, your levels should be when you were 20. Let's use peak levels of that age group, not your levels now. And some will say that's ridiculous. So you're going to have a lot of different opinions of what to do with your hormones, not based on the science.
Okay,
Based-
that's why I'm here, because you are based on the science.
No, but here's the thing. I don't know what's right for
Mhm.
you.
Well, but it's
I won't be doing hormone replacement therapy with you. You're going to need a prescription for that. You're going to need to work with a physician in your town for that.
Okay, so you cannot give me the prescription, but can you tell me what prescription I should get?
No. Technically, right now, you should be getting progesterone, estrogen. Like, what if you look at what's low?
Yeah, I understand that, but can you tell me which product, like Biest, is the one for me? Or what kind of progesterone to get? I think I read, I don't remember whether you recommended cream or the pills. I'm confused
Okay,
about that.
so
Can you give me this information?
I can give you some information, but let me explain.
Mhm.
My information won't be very useful to you.
It will not
No.
be. Oh,
Because
come on, come on.
because I've seen it so many different effects with so many different people,
Oh.
and it's like there's an absolute part of trial and error of seeing what you respond to. Like everyone's so different, and personally, like I'm not as big a fan as the creams because they tend to build up in tissues and body fat, and
Okay.
they're harder to measure.
Okay,
And
so
then
it is.
some people do better with like a sublingual drop. Some people do
Mhm.
better when they take oral. Like a sublingual drop gets immediately in there. For some people, that works best. An oral tablet takes longer to metabolize and get through your system. For some people, that works best. You know, there isn't. Then you have like practitioners that are just like they have a philosophy. They have their own bias. Like they go, oh, everyone should be on this natural cream. It's the best one, and it's like, how do you know that?
Mhm.
So it's filled with bias and not real information. Okay, so
I did understand that.
so you just have to. The most important thing to do is find a practitioner in your area because you're gonna have to balance this out for a while and get tested and retested. It's not like something you do overnight unless you're going just conventional Prem and Provera. Same for everyone. Okay.
Because this is the problem, because I've been looking for a practitioner that I can really trust, but with so many errors that I had to live through with the practitioners, it's very hard for me to...
You walk into anyone's office and give them your symptom and history, they're going to walk out. I would.
Good to know.
I think you're crazy, and like, I don't want to do it. That's what I would.
Yeah.
That's
Well, my
normal
brother
response.
wanted nothing to
Yeah.
do with it.
Yeah.
Exactly.
My brother was a medical professor.
Absolutely. It's 100% what would happen.
So
That's
how-
why then you get to the Lyme office, and before you even enter, you're already diagnosed. Then you get into the other office, and before you get diagnosed. So
Yeah.
you don't want to offload your
So
your
can-
signature attacks and all this stuff you have with someone, because quite honestly, it's too complicated,
It is very
and it's just going to make them
complicated.
think you're crazy.
Yeah, and
Versus if you say, listen, I have microvascular disease. I would say this: I have microvascular disease. I have neurological symptoms that have come in a stepwise deterioration. Sometimes I get severe brain fog, and just leave it at that. And don't get into like all the specific details.
So what kind of doctor would you refer me to?
The one
A
you can
naturopath?
communicate with best.
Well, I've been going through so
Try
many of them,
sales.
and communication is kind of okay. The results are not there, and the trust is not there because of that. So, like, would you say I work on this issue, hormone replacement, with a neurologist?
No, neurologists won't do that. Probably your best bet for first of all, my first question to you: do you want to do bioidentical or do you want to do
Bioidentical.
Okay, so then you're in the world of alternative medicine and preventive
So,
medicine.
are you saying if I request from a allopathic doctor by asked, he will not
You're in
give
Washington,
me?
right?
Yeah,
Yeah, so go to a good naturopathic doctor.
I know.
That's what you need. Go to a good naturopathic doctor in Washington.
And good is the question. Good is the question for me, because then if I go to the doctor and then see, I do not know what I'm reacting to. I start the hormone and I do not know whether I'm reacting to the hormone or to another trigger. So here I start this and I know already, like I took the antibiotics and it is clear by the morning I was dying. So I know
Yeah, it's gonna
it's
happen. It's
clear.
gonna happen no matter what.
With ozone, I was dying.
I
I was in the emergency.
I-
So I know
It's
that
gonna be the same.
the
It's gonna be the
connection.
same thing.
So how do I proceed?
You're gonna know it's unpredictable. You're gonna know you may have different reactions. That is some trial and error. And if you can find a dose that works for you, it's protective. That's the only way. Like, what do you expect? Someone's gonna like do a perfect lab test and go, "This is exactly you need at this dose, and this is how you, like that is not never gonna happen."
So, well, do help me here. So I start taking the hormone. I start taking the estrogen, biased, let's say. And
And actually, we're hoping it may not even. The key thing is it doesn't cause any adverse symptoms, and you can take it. And then,
this is easy, but my experience is not easy.
Right.
Usually it's the other way around.
what I'm trying to say is, we're not expecting it to go, "Oh, this fixed everything," or "This made a big difference."
No, I'm not talking about fixing. What we are aiming here, we are trying to get within that post-menopausal level that Dutch test is showing. So here
Maybe or maybe not. I mean, that's not true either, because the Dutch tests and any of these
Okay.
tests, they're made up. They're random. They're based on a general population. Well, honestly, what we probably need to benefit from you is the lowest dose you can tolerate. The lowest, that's not the highest. The dose you can tolerate without any symptoms that can still have protective effects for your brain and blood vessels.
And
does
how,
not cause any
and how
symptoms.
will I know that? Because
You'll
I cannot.
you'll probably have to work with your naturopath or someone who's
And
prescribing
what
and
test
say, I would like to start with the lowest possible because I have severe reactions to all types of things. And I want to start slow and low dose.
So she wants to go up, and when she starts seeing effects, step back.
Yeah.
And what kind of effects will I be looking for?
It could be
Except-
anything.
except for the levels there. The levels, if they are improving, that would tell me it's having an effect. Other than that, maybe it will be improving memory,
might.
but it is a slow
It's
process,
also
isn't
possible.
it?
It's also possible you go on estrogens and your brain fog dramatically improves for like the first 2 weeks, and then you kind of go back to where you were. But still, now you're taking it and it's causing adverse reactions. Now it's protective. You're just taking it to have a protective role. Like hormones are going to have a anabolic effect on your brain. They're going to keep your cells being able to divide better. They're going to calm down inflammation. They're going to help you with general growth proteins and growth factors that you need so you don't deteriorate as quickly. Okay,
Right.
it may not necessarily be something that immediately changes symptoms. However, with people that have neuroinflammation like you do, the two types of hormones that typically, if they're deficient in, like take the brain fog away, and it's not permanent, it just takes away for like a honeymoon phase, is typically estrogens and thyroid hormones. Now with you, it's clearly not thyroid, but it's for sure your reproductive hormones. So when you look at having a history of microvascular disease and what things can be protective, hormones are one of them. And then when you look at your real history of like how complex and everything is, and how you're so reactive to many things, you just want to go slow and careful, and make sure once you get on replacement that it isn't causing any adverse reactions to you. Get a gynecological exam on a regular basis, because you're in part of your game is how do I slow this down so I can maintain as much function as I can, and that's where the hormones will come in. And they may even have some impacts on your symptom, but typically it's short-lived, and they still have long-term protective effects.
Okay, I understand that part. Let me ask you this. So, what is my end game with this microvascular disease? Is it a stroke? Is it dementia?
No, it's just stepwise deterioration.
Yeah, but how symptomatically is that reflected?
Worst scenario?
Yeah,
Worst scenario, you get a bigger one. You get a bigger
a
insult.
stroke.
Yeah,
A stroke.
more of a or more severe of a microvascular disease with more noticeable symptoms. Okay, you definitely are at higher risk for a stroke. More so if your blood pressure is high. If your blood pressure is not high, it's not as likely. And just think about the worst scenario is just accelerated brain aging.
So this is dementia.
Well, it's only going to be dementia if it impacts your cognitive centers, but it can impact your thermoregulation centers.
It is impacting all of them.
Exactly. That's what I'm saying. So it's not going to be like you're not going to fit the dementia category. It's going to wherever it's having its degenerative effects most is what your symptoms will be. So it won't be specific to Alzheimer's or any other neurodegenerative disease because it'll be different. Now, you could maintain it, and it sounds like you have been maintaining it. So don't lose hope and all that, and but there's.
Well, my symptoms are getting worse. Maybe hyperintensities are not, but my symptoms are.
Yeah, so brain inflammation can get worse. Okay, so here's what you have to also understand. There's a concept called inflammaging. Okay, so there's a field of science called geroscience. Gero being as you get older science, right? Geroscience. And researchers in that field have found that as we get older, we just get more and more inflamed. And the reason that we're getting more and more inflamed is they use another term called garbaging. We get more garbage in our cells. Our cells have to be cleared out. If our cells are not cleared out, they cause more inflammation. So you have a lot of garbaging if you have microvascular disease because you're getting bursts of injury to neurons, and neurons are dying. Cell structures are broken. They're just sitting there in the brain, right? The more and more garbage you get built up in the brain, the more the glial cells get activated to clean it up. That's their job.
And with insomnia being a constant, then it's not getting cleared as much, right? With
Maybe.
lymphatic
I don't know.
system.
I don't know. But any neurological symptom may be part of it. Insomnia is definitely brain. Like in order for you to fall asleep, that's brain. Your brain has to shut down your reticular activating system so you can fall asleep. So you can do things to promote like clearance of autophagy, mitophagy. First thing would be get your ketosis. You may we may even want to do some fasting. The only thing that really helps autophagy is like once you get to about a 3-day fast, that's when you really start to get debris clearance. That's been studies from animal studies, because they don't do that in humans because they can't dissect their brain out and see what's happening with fasting and not fast. But comparable data can be extracted from those animal studies. So like there's a big part of trying to calm down the amount of debris and inflammation you have unrelated to your microvascular disease, because the symptoms you have all the time are brain fog. It's inflammation. So part of it is your inflammaging. The more debris you continue to have in your brain, the more inflammation you get. The only way to get rid of that is to turn on autophagy and clear that out. Okay, you're already taking lots of anti-inflammatory nutraceuticals for brain inflammation.
And I do want to go through that
Yeah, we'll
list
go with that.
with
Yeah,
you.
yeah,
I
yeah.
would really
It's a lot. Yeah,
appreciate
yeah. But it's like the bigger picture is it's the microvascular disease. How do you slow that down? How do you keep your vascular health healthy? And then how do you get rid of some of the microglial activation inflammation that's already there? And it's a long process, and like you're gonna have to like go through it and try different things. Hormones will be part of it. Like hormones will help you with getting rid of unhealthy mitochondria, mitophagy. They do have an impact on getting neurons to reconnect to each other, synaptic activity. So it's a matter of like what variables can we add in that lean you towards better function recovery versus if you do nothing, you're going to have more debris accumulation, more buildup, more age-related inflammaging from all that debris, and more brain fog. And then you're going to be more sensitive to anything immune trigger that activates it.
And would you say, like, my day schedule, like lying down, like
Yeah.
3 o'clock, is that okay, or should I be pushing more
No,
for
you
activities?
shouldn't push more.
Should not. Okay.
You should be as active as you can, but when your brain needs a break, you need a break.
Okay.
Like, listen to your brain. Like, when your brain tells you it's tired, don't push it. Now, the most important thing for you will definitely be physical activity. Like, your walk is really important. All the cognitive things you're doing is maintaining your function. You know? Here's the thing, too. Like, you can look at... there's two things that's happening. One is you're getting injury from the microvascular injury, and the second one is how your neurons go around it and connect. Plasticity, right? So you could have one person that has severe microvascular disease on MRI, and someone has mild, and the one that has mild has much more severe symptoms. Because even though this one has more injury, this one has adapted and has neurons connecting to each other and is functioning, even though they have less of the injury. I mean, they have, the one that has more injury could be functioning much better because they can have neuroconnectivity with the neurons they have, right? So all the things you're doing with cognitive tasks are supporting plasticity. And plasticity is like where hormones come in, physical movement, activity comes in. The exercise, if you stop moving and exercising, you will go downhill fast.
I don't know.
Yeah, no. It's for sure. And the more frequently you can do that. So with blood vessels, the higher the intensity, the better growth factors you relieve, the more nitric oxide you release. But I don't know what intensity you can handle.
Yeah, I'm listening to my body.
Okay.
I'm
Let's
constantly
stick with
listening. It's like I can do it. I do it. I mean, I do push sometimes when I really can't because it's circumstances, right?
that. Okay.
A quick question. You were mentioning nitric oxide impact. Would sildenafil or its equivalents do anything to improve our nitric oxide level?
We are doing this nitric balance.
There's nutraceuticals that raise it, but like nitroglycerin and drugs like that, they will prescribe them if symptoms get more severe and worse. Traditionally, other than that, they would never prescribe them.
Okay.
So you get someone who's like
This is not
outside of standard of care. Like, and most people don't like to go outside of standard care because then they get liability legally and things like that. So yeah, ideally, like you think some nitroglycerin, you'd have some dynamic change. But then what they also find long-term nitroglycerin can actually impact vascular health. So it's probably best. And it could probably improve your symptoms, but it could do it for years and years and years. May not be the best thing. Now, more than likely, so one part of this is we go into like your strategies, and one of them is like this whole endurance thing is figure out the HRT thing. It's going to take you a while to figure out. Trial and error. Don't expect anything other than see what your body responds to. Okay. Second thing is you probably want to get you in ketosis.
Okay.
Once you get into ketosis for a while, the only way to clean up debris in your brain that science has shown that works is autophagy. There's no supplement that does that. There's no
And fasting, right?
yeah. But once your body gets used to being in ketosis and using ketones for energy, you can go into a 1-day fast and eventually to a 3-day fast, to a 4-day fast, and start cleaning some debris up. Okay.
But there's also this theory of not staying in ketogenic diet. I understand.
Yeah, you want to break out of it at some point.
And
now,
how long would that be?
months. There's people we have that have seizures. If they're not in a ketogenic diet, they would have a seizure the next day, and they've been on it for 30, 40 years. Like no one, when people say we don't know if we should be in ketosis for long, like It's not true. You're just assuming that because no one has published on it. But people in ketosis long term for medical conditions all the time. You know what I mean? Like, be careful. Like, there's a lot of YouTube experts that don't know what to talk about. Now, for people that are athletes, some people, when they are trying to lose weight and trying to get lean and cut, they find if they get out of ketosis and get back into ketosis, they have better changes in metabolism. But we're focused on your brain health and getting your fuel delivery and all that. More than likely, if you end up doing long-term ketosis, if you want to take a break, you can take a break. You can go back in ketosis within 1 to 3 days. It's no big deal. But we want to get your fuel and efficiency working better. Then we want to clean out some of the debris, and then you start getting some HRT. Now we're starting to do things that can impact your brain inflammation, your microvascular disease to the next level, right? You're already taking a lot of nutraceuticals and things like that. Let's talk about triggers from the other side. So endurance, it's kind of nice. It's hard to tell your endurance because your sleep is all over the place, but it doesn't seem like, other than blue light, that's the main thing that's really fatiguing your brain.
I cannot tell you what's fatiguing it.
Can you pay attention? Like,
I don't think I am paying attention. It's just so that I cannot pinpoint that there is one thing. So here I am, okay, like then I feel like I cannot be like, I can clearly see that with studying, right? So when let's say I read Karazian's book, right?
yeah.
There is only this long that I can read it, because you have to follow, you have to really understand it, you have to really pay attention to these things, whatever you have to correlate all this, you have to put it somewhere there, right?
Yeah.
So I'm reading like for, say, an hour. I can read it for an hour, yes, depending upon how I feel on that particular morning. This is in the morning only I read that. I cannot read it in the evening. So, okay, but then it is morning and it is not 9 o'clock yet. So what do you do next? Then I get a different book, okay? And it can be on like this health expert's book again, but it has to be a much easier book, right?
Yeah.
Or then I read like The Economist, right? This is much easier on my comprehension as well. But I can see, okay, now I have to stop reading because I'm not comprehending well.
Right.
But so would you say endurance?
So I would say your cognitive endurance is pretty good. Let's talk about your physical endurance. Your physical endurance, like we go for a walk and you do stretching and all that. What's the intensity? How long are you going? What are you doing? More specifically.
Depends very much upon how I'm feeling at that moment.
Okay.
I'm listening to my body, what it tells me, where are the symptoms intensifying, right? So like, okay, I feel this over here, as I'm walking up the hill, that means I need to be turning around, and I do push a little bit so I get to this table, because this is where I can do my exercises. After I do the exercises, sometimes I can go further.
Perfect.
Because the exercising makes me feel better.
Okay.
Stretching,
what can you do to increase your heart rate without stressing out your body?
Dancing.
That's
I do not know what you call it, stressing the body. I can do
higher intensity, your heart rate going
It
up.
is very high intensity.
Dancing.
This is this beautiful. I can send you that music so you can dance. This is beautiful.
Traditional.
Okay.
Yeah, and so I can do 3-4 dances of that.
Okay. Can you do that every day?
I would like to. That doesn't happen every day because, again, it depends upon how I'm feeling. There are days when I cannot walk or I cannot dance. There are days that I prefer walking because it's nice out.
What would happen if you did do it
every day?
Yeah.
Let's
would
see.
happen?
Let's put it on the schedule. Let's see. So you suggest I do it every day?
Yeah.
Okay.
Listen, the more intensity you can have with your movement, the more vascular endothelial growth factor, the more nitric oxide, the more neuroprotective chemicals you're going to release in your blood vessels.
Yeah, we do take nitric, your
I know,
nitric
but
balance before we go exercising.
Perfect.
What
Oh, you
we
do that?
Yeah,
Okay, that's
yeah.
great.
Yeah.
So that's perfect.
And hydrogen water, we take nitric balance and
Good.
hydrogen water, and this is
That's
how.
perfect.
Yeah, that's what we.
When I was
do.
reading your case review, I'm like, oh wow, you're doing a lot of good things.
Well, it has been how many years since 1992? There was a lot of time to learn.
But no supplement can have the same effect as you can when you physiologically change your heart rate
Okay.
and get that up. Okay.
Okay,
So
so dancing is the best for that.
Dancing will be the best, and
Okay.
also well, anything that raises your heart rate. So free fit dance, that's dancing, that's great.
Okay.
But even sometimes people have people just like lie on their back and just move their arms and legs as fast as they can for 20, 30 seconds,
Mhm.
and then do that again and do that again, and that's how they get their heart rate up because they can't really stand, they can't really move, they can't do anything.
Mhm.
But higher intensity activity, even if it's for bursts for 20, 30 seconds, that are done like over, let's say 3 to 5, let's say you do 30 seconds of high intensity, do that 10 times. So now you got 3 minutes of really high intensity exercise, where high intensity being your heart rate's high enough where it's difficult for you to talk.
Mhm.
That would be high intensity. That's going to have the most impactful impact on your blood vessels. Lower intensity, like when you go low intensity, you don't release growth hormone.
Like
When you-
walking, like
Yeah.
okay.
You just don't get the same neurochemical response in blood vessels. It's still good for you. You get blood flow, you get oxygen, you're stretching. That's good for your brain, but
Mhm.
it's not going to be the key way to
Determinant.
turn your blood vessels on.
Okay, how about jumping on the trampoline? Does
Sure.
that? It does already,
Just do
right?
that. Yeah.
Okay, because I do that too. I cannot do it for long because of my broken legs, because then I get the pain there, so I have to stop. But
You
I
can
do
wear.
that.
Have you ever worn a heart rate monitor to look at your heart rate?
No, I don't think we have. We do actually have that on the finger. That one.
That's a pulse ox.
Uh-huh.
No, heart rate monitor is like you wear a little strap around your chest and you have a little
Okay.
watch.
No, we
and
don't
then,
have that.
And then measure your heart rate.
No, we
They have
don't.
newer ones where they can just you don't have to even wear a strap anymore. You get those at the sporting goods store, or you can get it online. It's a heart rate monitor.
Okay, heart rate.
So you want to see, do that. So get a heart rate monitor so you can see what your heart rate is when you're dancing
Okay.
and other activities.
Good idea.
Because high intensity is where the magic happens for
Okay.
blood vessel health.
All right.
But it's also where you can really fatigue your brain, and like need to, But
We'll
you
do
have-
listening to
you
my
have-
body,
yeah,
right?
Yeah, listen to your body. Right now it seems like
finger measure actually does your pulse.
You cannot do it
No,
when
not
you are
in that
moving, darling, because it doesn't show.
it'll
the-
fall off.
That other one was doing it. I remember taking it something.
Okay.
So
Yeah.
with the new pulse heart rate monitors, you can actually have your entire heart rate measured for 20, 30 minutes, and then put it on your computer. You can see how your heart rate was during your whole workout.
Okay.
And we had something I was doing in some of the walks, and I was checking to see how.
Yeah, but
My
you
pulse
have
was way up.
then to stop, darling, for it to show you proper measurements.
So again, heart rate monitor, okay?
Yeah.
Yeah.
And then more than likely, we have to increase your intensity, get your heart rate up, that have some major effects on your blood vessels and blood flow and circulation, okay? Get you in ketosis, transition into prolonged fasting, like into eventually a 3 or 4 day, okay? Get rid of buildup of debris, okay? You don't know what your triggers are, right?
I don't. And I've been trying so many years.
Let-
I've been trying so hard. It is not food. It's my impression.
Okay, it's possible. Let me ask you a question. Actually, before I ask you the question, you also have to remember that things that fatigue your brain don't necessarily do it immediately. You can have an event the day before
Yeah.
that then fatigues you the following day.
Yeah. I
So-
notice that.
Okay,
It
so
happens.
what have you noticed? What kind of things fatigue you?
Well, yeah, I would say that it is fatigue. I'm talking in relation to signature attacks, right, and
Okay.
side effects. Like I took the antibiotics in the evening. I was dying in the morning. So this reaction. Then I would get stressed out in one day, and then it is the next.
Yeah.
No, it is. Is not the proper verb tense, because this is what used to be. Nowadays, things get so much faster. It's like I get upset, and like in several minutes, here your signature attack.
Okay.
So now it's kind of like there's no that time lag anymore.
Okay, right. Why are you listening to the news every day? Can you stop? It's not
I
going to be good
can't.
for you.
I know, I can't.
Can't you just talk to family?
I do talk to family, but I know that is stressful.
It's like the worst part of the news is all the bad stuff.
It's kind of like I've got this anxiety because I do not know what's happening and how it's going to go for my family. My mom is 83, all alone there. I mean, my sister is there, but not on such good terms, right? So it's like she's all alone in the house, and I need to understand what's going on when it is my time to tell her, Mom, get out of there. How can I not understand the situation? I am on high alert there. It's like my life is there, right? It's like my family, my friends. I need to understand the situation, and here is Lukashenko with his threat that maybe the atomic bomb is going to be thrown in Ivano-Frankivsk region. So I have to tell them, get out.
So it's helping you deal with your stress, to know what's happening.
Absolutely.
Okay. All right.
I understand that you should not be watching news. I understand the stress that it produces, but it is more stress for me not to understand the situation.
Okay. All right. Do you have reactions to mold? Every time you test, you have mycotoxins, you have high antibodies. There's a possibility you may actually have mold allergy. You know the difference?
I do know, I understand the theory between IgE, IgG,
Yeah.
but what I do not understand is what I do have the reaction, what I have the IgE reaction. I would say I do, because like this is also a reason, maybe within the last couple days I get runny nose when I go for my walks, hikes, when it's raining. So I would think this is mold, but some doctors tell me, no, this is not mold. And I'm confused there. What's your take on that?
I'm not sure. I would think it would be, but let me ask you another question. Do you want to do the IgE test? Do you want to know?
I would.
Okay.
I would like to know whether I'm reacting. I do have this recent testing that kind of shows, but Dr. Parpia told me, no, this is no big deal. Which one was that? Let me think. That showed so much reaction to, and I think it was IgG testing, and like all of those.
It was IgG. The one you
It is IgG.
You've only had
You found it.
IgG, and you're
Okay, yeah.
Yeah.
I did ask an allergist, a regular allergist, a while ago, and she did some testing for me, and she told me, no, there is no, this is, what did she say, rhinitis, some kind of rhinitis that I got. This is what she told me. But I would like to do the proper testing to understand whether I have the allergy or sensitivity.
So we can do an IgE test for you, okay?
Okay.
So now we're getting into, we talked about, like, you should really think about HRT, with your family history. If you do go on it, get checked regularly for gynecological exams.
Yeah.
We're gonna just go aggressively, since food is only fuel for you at this point. Just get you in ketosis.
Okay.
Get your body adapted to a ketosis state for a while. Then get into long-term fasting to get rid of the inflammation, the garbage in dead cells, all that. And then we need your exercise to go into higher intensity. So all those things are there to try to change your lifestyle for various factors that improve your blood vessel health. Okay,
Yeah.
You're already taking great nutraceuticals. Doing that, you're taking things to support your nitric oxide before your workout. You're taking magnesium. You're taking anti-inflammatories, neuroflam, like things that can neuroglial inflammation. And the good news is you figured out what you can and cannot tolerate. And
guess who told me to do neuroflam and stuff? Dr. Karazia.
Right, he's a smart guy. Anyways. But now we have to look for things that can activate your glial cells. So when you activate your glial cells, with your history, like when I look through all your labs, you're definitely reacting to mold, like you have antibodies. And so the IgE will help us know if you have allergies. Now if you have allergies, this is what we always do with people that have mold allergies. First of all, we get a hygrometer. You know what a hygrometer is? It measures the humidity.
We do have
What's
this.
your humidity in the house?
It is high in summer. It is okay. And we were talking about getting something linked to.
I was wanting to dehumidify it more, but with air conditioning, we're never above 60% in the house.
Yeah.
and we're usually below. I'm sensitive to mold.
So you want to? Okay. So you want it less than 50.
Yep. So it's normally it's normally below 50.
It normally is.
We have air conditioning.
We're
in
just
the
worried
house.
about the abnormally.
We have air conditioning, so summer is fine, right? With air conditioning, you lower the humidity, don't you?
Well, it tends to remove water, but I was wanting to reduce it lower.
You wanted to get it lower.
We were talking. He was talking to do that like centrally for the whole house.
Do it. If you're
Okay.
both sensitive to mold, then invest
I've always,
in doing
I've always had that's why I've always had an allergy to mold. We had the house tested for mold before we came in.
Yeah.
It was clean, and I put central air in immediately. And we had a central air M16 filter,
Yeah.
and we have Austin
Air filter.
carbon and HEPA filters in the rooms.
You do have HIPAA filters? Okay, that's the other thing we do. What was the date of that last mold test?
You
I mean, I
mean-
have it, but do you know what it is? Was it recent?
Are you talking real time? and-
IgG. No, not IgG.
No. That when it was maybe 2-3 months ago
So that means you're still getting exposed.
in the air
Yeah.
outside.
Yeah, maybe.
I mean, this is
Well,
Washington.
we're in the Pacific Northwest,
Right.
so the
The inside one is the one we're most
the
worried
inside-
about.
inside's
Let's get
pretty
your
well cleaned.
environment.
Yeah, and I spend a lot of time. I'm gardening. I have chickens. I'm outside a lot, and I do this hike, so I'm outside. So this is obviously where this reaction comes from.
Well, you notice it when you're outside more.
Yeah.
Okay. Is there certain areas where you take your hikes and you notice it more?
That's-
Like
I
you go
don't
deep
know.
into the forest and the woods, or what do you do?
No, it's actually the one that we kind of moved from one place to this gold bar because of these Wallace Falls. Have you been to those areas now? There's this beautiful trail, very popular, and we bought the house right next to it.
Okay.
Obviously, 5 minutes you can walk there. But yeah, and this is where I walk most of the time on the weekends because he works on the weekends and I cannot really drive much. So we go high in the mountains, and maybe I do react less there. I did not pay attention. I just pay attention because this is where I go on walks all the time, and this is where I notice that I react. So are you saying that I could react more in one area of the forest other
Yeah.
than in the other?
Yeah.
Not going to change because I cannot
Okay.
drive far.
Okay,
So
that's fine. Let's just make sure your house environments. You get the purifiers in every room,
Mhm.
and you get the dehumidifier.
I haven't put a central dehumidifier in. The house has a central air and a heat pump.
Get one if you're already thinking about it. If you're borderline,
Yeah, he was talking about it last. Yeah, we will. Thank you.
Well, more than that, I have an efficient dehumidifier in the crawl space. I have an efficient dehumidifier in the garage, and I have an efficient dehumidifier in the back storage shed. So that
that
stuff
works
doesn't
too.
get mold.
If you could just check
The house is the only thing left. So
just check, especially in the bedroom, what the humidity is, because you're sleeping many hours there. The rooms you spend a lot of time in, just measure the humidity, and if it's
Okay.
and try to get it less than 50%.
less than 50.
Even better if it's lower. Okay, less than 50 for sure. And then make sure at least that's happening, because then we can change the environment of at least
Yep.
ongoing brain inflammation from mold sensitivity.
And this is the one selling that
It's just hygrometer.
Yep,
just
we
to-
have. it
we
looks
have
like-
this. We
Yep.
have the hydrometer. We do not have the dehumidifier. Is that what?
Well,
you
we
said?
don't have the dehumidifier in the house. We don't have the central dehumidifier. But
So
you don't have to central. You can just get one like a portable one.
I actually have much better ones than that.
As long as you keep that humidity less than
Yep.
50%.
Yep,
and
no,
we
that,
got that part.
yep, I know how to do it. I know which ones to get.
Okay, perfect. And you get the HIPAA filter, which is great because they get rid of all the particles in every room.
Yeah.
Okay.
Yeah, well, we've just went through 6 weeks of bad smoke, and that filters and it deals with the smoke too.
Perfect. That's great. Okay, so you already have that. All right, so you don't think there's food. You put in here, like, I haven't been able to get off dairy. What's the problem with that?
Well, it's like the food that you used to. It doesn't taste the same.
It's,
It's
probably
a-
the most likely food causing your problems right now.
Well, I did do that testing, and let me understand this part very clearly, because it matters, because it's every day you eat. So I do have lactose intolerance.
Okay.
I'm not reacting to casein. I did Cyrex, doesn't show. And this genetic didn't show, it showed lactose. So do you think that because it is so inflammatory, I should abstain from all dairy?
Okay, a couple things. First of all, lactose is different because it's the sugar that you can't digest, and
Right.
immune reactivity, which is more concerned with, is the casein and also butyrophilins, proteins, and there's various subsets of those. It's not
Okay.
When you did your Cyrex test, your general antibody count during that time period was on the low end, like your IgG, IgM, IgA. So possibly you may have had some false negatives.
Mm.
If you look at
So-
your IgG levels,
I
you're right around like normal.
I did pay
You remember
attention.
that?
The doctor didn't tell me anything, but I did pay attention that everything is on the low end.
Yeah. So like when I looked at your results, I'm like that's a possibility you could have had false negatives.
But I did have some positives too.
You did.
Not many, but some. So
it's not all or none. It's just less efficient.
So
right?
what is the practical conclusion
Practical
then?
approach is get off milk.
No. How do I practically ascertain that I do need to get off it? Is there any way to...
Try and error.
You haven't been using milk per se. There's some sour cream.
Yeah, and
that-
this is... I put it down, Dr. Kreisen.
We did a study, I can't remember what year it was. We did a study. We looked at healthy population. We had 400 people in the study. We checked for milk antibodies. We checked all the different milk proteins, not just casein. Different variations of casein and different butyrophilins. We did the same thing with wheat, right? We found X amount of the population had these antibodies, right? And then we checked them for brain antibodies. Myelin basic protein, neurofilament, myelin glycoprotein, cerebellar antibodies. The ones that had the antibodies to milk had the highest degrees of myelin inflammation. And we actually published that saying neuroimmune reactivities in normal populations.
Mm-hmm.
And there was this direct statistical correlation between milk protein and myelin. I don't know if there's cross-reactivity there, we didn't go that far. But
So are you saying that regardless of what my testing might show,
Yeah.
if my immunoglobulins
Yeah.
were okay, I should still go off
Yeah, and
all dairy?
and gold standard is actually elimination, provocation. You eliminate the food for a period of time.
But see, with so many symptoms, so much inflammation,
Hard to tell.
whatever, I cannot tell. And I did try to pay attention. So, okay, I'm like with that SIBO, I was off all dairy and everything FODMAP diet. So I didn't have any. Well, I have to say that I did feel, my brain
Yeah.
did feel a little better with...
Get off dairy. That's always happens with people with gluten dairy. I did
Okay.
kind of notice it was a little bit better. You're fighting for inch by inch.
Yeah.
You're trying to get as far as you can and slowing this down. Inch by inch is all matter. Like there's actually nothing worse than gluten dairy for brain inflammation. They're just the most common reactive ones we see clinically.
Okay, agreed.
Just get off.
I will, darling, no more sour cream in the house. When I have this emotional eating, this is...
Try coconut milk alternatives. Coconut
Okay,
cheese.
I
and stuff
do,
like that.
We
except
use
that...
coconut milk for, we've already done that full transition. It's just the sour cream.
It's just a sour cream.
It is just the sour cream. Like once in half a year it is cream. Like recently I made apple sauce and then I added a little bit of cream. That is so good. Try sometime.
I'm sure.
But
But
then
we've switched to coconut milk.
there
don't
was
like
coconut milk. I do like coconut milk. It doesn't like me. I did
Oh.
food testing and I tested positive for that. So I abstained from it and I am back on it. I did Cyrex, didn't show that I react to it, right? But once I showed it once, I do not really want to have it so
I
much.
don't. Well, just don't do milk. Do whatever you want with coconut, however you feel like it. I honestly don't care.
Okay.
But milk is so reactive.
Okay, I got you.
Just
Okay,
stay away. Stay away.
that's a done deal.
Okay. No dairy. Okay, great. Okay, so
I don't want to. Can I ask you about lectins here?
yeah, you showed up like when you looked at your food sensitivities. There was nuts. It looked like a lectin pattern starting to develop, but it wasn't all lectins.
It wasn't nuts. It was just one nut.
Oh, was it? It was in more than
Yeah,
one?
it was maybe
Sure?
two. No more than that. Okay, let me think. It was Brazilian nuts,
Yeah.
and it was, let me think.
I can look it up. It's in here somewhere.
The one that I never actually eat, I do not know why I should be reacting
Almonds?
to. No,
If the proteins are similar from one nut to another,
I
they
see.
can, oh, by the way, this is your SIBO test. See,
Okay.
at 90, see how you start to go above 20, 85, 43. See what it says here? A rise of 20 between 90 minutes indicates suggestive of a
Yeah.
positive test.
Yeah, I knew it was positive. That's why I went on
That's-
that diet. But I thought
It was
it was not
hydrogen.
right.
It was hydrogen.
It was hydrogen.
Yeah.
Okay.
Let me see.
Cashew. Okay.
Cashew. Yeah.
Cashew.
So if the proteins are similar from one nut to another, then you can react to them even though you
Yeah.
haven't eaten.
We did. I was into Brazilian nuts because of selenium at one time, but then I saw that test result and I stopped.
Okay, so here's this. Kidney bean showed up.
Mhm, yeah,
So that's a lectin.
that's all right.
Brazilian nuts, cashew, that's a
Are
lectin.
pinto beans,
But I
Green
did-
nut showed up. That's lectin.
pinto beans are a problem?
No, it's just we're just looking for a category of lectin.
But is that the lectin in the beans that makes me react
not
to it?
necessarily. But
And isn't there a test? Isn't I think Dr. Walls talks about Entero lab that does this lectin testing?
yeah, I mean, you did test your lectins. There's no better way than this one because it actually breaks down. See, it says agglutinins being agglutinins. It actually tests the lectin. It tests lentil lectin. So when you do a food sensitivity test, they take the whole protein. They take, let's say they do lentil. They basically take lentil, take the proteins from lentil, put it in a dish, mix your blood with it, and see if it reacts.
But I did not react to lentil,
I know,
just
but I
the
want you an
kidney.
understanding. But they checked lentil lectin, so we know what they did with that. Is they only took lectins from lentil, put it in a dish, and put your blood react against it. So it's the most sensitive way to find lectin sensitivity.
And I'm not
You're
sensitive.
not
to
sensitive here. But again, this is the time frame of your antibodies
Mhm.
or your immunoglobulins were on the low end.
Yeah,
See?
yeah.
Your immunoglobulin J should have been up to 751 and 1,500. You're right up on the border of 169, right? Your immunoglobulin A,
Yeah,
820 to 453, you're at 126. Your IgM, 46 to 304, you're at 87. So that's why I highlighted these. I'm like, wait,
Right. I did, yeah, like I told you, I did pay attention to that it was all on the low end. Is there any way to raise this?
yeah, you can raise it.
How do you do that? Like
Get sleep, see all
immunoglobulin.
the things you're doing, get off milk. There isn't a supplement necessarily. Okay, now, so one of the things from history was the mold. So it sounds like you got that, under control. We check for IgE, okay? The other thing is you definitely have some reactivations of viral patterns. Like most of the
Yeah.
viral patterns you have are totally useless because they're just past exposures.
I didn't understand that.
So when you look at like viruses, you had like
Yeah.
cytomegalovirus, whatever.
Yeah.
You check IgG or IgM,
Yeah.
right? So majority of the population has antibodies because they've been exposed to IgG. Doesn't mean they
Yeah,
have.
but Dr. Perpia told me that if it is 4 times the
That's
amount,
made up theory. No.
okay. And Dr. Carnahan, which is she is pretty reputable. She says 3 times the level means it was reactivated.
No.
And you say
It
what?
can be re-exposure to something you already have immunity to. You can raise your antibodies. Like if you have some antibody from past exposure, you get exposure again, your antibodies go up. Doesn't mean you're reactivated. So this is the hardest thing in immunology. So the way you actually really know if you're reactivated is you actually have your immune cells that fight an infection change. So if let's say your cytomegalovirus was up,
Okay.
at the same time, your natural killer cells were screaming high. Your T cells were off. That means you're fighting an infection. You're reactivated. Just the antibody itself. Like the antibody itself just goes up and high from your immunity. Your actual response to a virus will be measured by T cells. Now, there's one
Nobody is
period.
doing this.
They did it
testing.
once. They did it
They
once.
did?
Yeah. One person was one that rechecked you for Epstein-Barr reactivation. And during the Epstein-Barr reactivation, your lymphocytes were high, your neutrophils were low. So I would interpret that as they probably had an active reactivation.
Okay.
The other tests are just getting antibodies for themselves.
Okay, that was with
Listen, the world of experts is nonsense. Okay, because you have like people that keep saying the same stuff. Like they say like CD57 is associated with Lyme disease, and they're like, no, there's actually nothing on that ever published. This is just the garbage people pass out. Antibodies 3 times, 4 times actually mean no, they don't. Like, this is nowhere in the world of immunology isn't published. It just gets regurgitated in the world of alternative medicine, and then people all of a sudden do it, and then like, oh, this guy knows because he knows it's 3 times normal. Like, no, it's completely made up.
Okay, so are you saying I do not have chronic infections?
I'm saying you do have a potential for immune reactivation because you did have a pattern of Epstein-Barr reactivation with the lymphocyte high viral load. Like, you had the
Epstein-Barr.
yeah. But I don't think you have as many viruses that are ongoing as serious as you may think. Okay. That being said, since we're going to do your antibodies to mold, IgE, to see if you actually have an allergy, because you definitely have exposure, right? That would explain like why you're so sensitive to things all the time. Is also to run a T and B cell panel and just get an idea what's happening with your immune function. Like
I would
metrics.
really want that. I
Yeah.
would really like an exhaustive study of my immune system to see what's going on there and if there is anything we can do about it.
Okay, so we're going to check your immunoglobulins, your IgG, IgM, IgA again, and we're going to do
Okay.
a T and B cell count,
Okay.
and then we'll do the IgE to mold.
And that's TH1, TH2.
Those are the cytokine markers. Because they're not that reliable right now because
Okay.
we're only getting levels. We used to be able to do what's called a cytokine stimulated test, where
Mhm.
they would take your cell in the lab in a dish and expose it to a trigger and see what cytokines got released. Now they're measuring levels only, and when you measure levels only, unless you're extremely active on the flame, it won't show up. And the problem with each of those cytokines are one's $150, one's $250, one's $300. So you could easily spend like $2,000,
Yeah.
and it's like you're not even very
Gotcha.
likely unless you can have nothing show
Yeah.
up. Yeah,
Okay.
and it wouldn't necessarily change your treatment. And
This is what matters. Okay.
so it's not so important. So let's do those. We do with blood work we pay an extra like $85 and get vitamin D and C-reactive protein, homocysteine, and fibrinogen and some other markers as a routine. So we should probably just add the routine part of
Okay.
it to it.
Yeah.
So I don't know what the exact number is, but probably around $400 is what the blood work will be. Okay. And then, is there anything else you want me to test with your blood work?
Not that I can tell you
Are
off
you
the
picking
head.
her hormone levels?
They're gonna probably do an updated one whenever
Yeah.
she finds someone to work
Yeah,
with.
I think I'll work with Dr. Sanders on that.
And I'm happy to communicate with them. It'd be
Yeah.
better to say, listen, can you just be a player on this part of it? Because if you
Okay.
have too many people trying to do like functional medicine, diet, nutrition, it's going to mess everything up. Just
I
say,
agree.
so if you work with them, say, can you please just handle this part with me? And then by the time we get done, I also have it takes me a day or two to write it. I have a narrative report from your exam findings, our plan, our impressions. You can share that with them. It's for your medical records.
Yeah.
And then I'm happy to speak with anyone that you're
Great.
working with.
Thank you very much.